Black women are over 2 times more likely to die during childbirth than any other ethnicity, and almost 4 times more likely than white women. I know, not a very exciting way to start the talk, a bit depressing, but it is the cold and blunt truth, and it needs to be talked about. So, you might see this as just a sad statistic, a sad figure, but I want you to truly understand that every single mother here is a mother who never made it home, a family left grieving, a community deeply affected. And there may be some of you in the audience thinking it's just due to biology, things that we can't do anything about. But I'm here to tell you that it's not. All the evidence points towards this being avoidable factors being neglected. So if this pain and suffering caused is not inevitable, it's preventable. And the question is, if it's preventable, why is it still happening? And that's what I'm here to talk to you about today, the hidden color that resides in healthcare. And today I'll be discussing and raising awareness of these racial disparities that occur in healthcare, what can be done to help solve these, and what me and you, as a student body, can do to help this. So I've talked to a couple of people about this before, and a common question that often comes up is it just due to deliberate racism from our doctors? And that's one misconception I want to eradicate now. Majority of the time, it's not due to deliberate conscious racism from our healthcare workers. It's due to this thing called subconscious cognitive biases. Okay, I want you to bear with me for a second. Could you, everyone in the audience, just close your eyes just for like 10, 15 seconds? I want you to imagine you're going on holiday, you're at the airport, and you've just been called to board the plane. You're walking up the stairs, you shake hands with the pilot, and you go to take your seat. Okay, you guys can open your eyes now. So what I want to ask is, could you have a raise of hands if the pilot that you imagine looked more like the gentleman on the right? Okay. And could I have a raise of hands if the pilot looked more like the lady on the left? Yeah. And this is pretty much representation of what these subconscious cognitive biases are. And it's essentially those snap-second decisions that you make in your head based off of stereotypes or past experiences that you may have held. And these biases directly impact healthcare, whether it be through diagnosis, through treatment, through access. And they affect, these biases happen on a systemic and a clinical level. So, what are these clinical biases that I'm talking about? So not too long ago, maybe 10, 15 years ago, a study was carried out where some medical students and resident doctors in training were asked to assess patients' pain. So over 200 participants were involved, and each of them were given identical cases, whether it be a broken leg or a kidney stone. And they were asked two questions. One, how would you rate the pain of this patient? And two, what treatment plan would you carry out? The only difference between these identical cases was the patient's race. Some being black patients, others being white patients. In the same study, these medical students, the participants, they were asked about biological differences between white patients and black patients. For example, black patients having less sensitive nerve endings. And I want to clarify, these conceptions and these differences that they were asked, they were all false. But surprisingly enough, over half of the medical students and the resident doctors in training believed at least one of these misconceptions. And those who held those false beliefs consistently rated black patients being in less pain and gave less accurate treatment plans. What, on a more hopeful note, is those who didn't believe in these misconceptions consistently showed a lot less bias in the treatment and the rating of pain for these patients. So this just goes to show these clinical biases that occur in healthcare are not the deliberate, they're not the intentional thought of doctors. It's just due to assumptions or misconceptions that they may believe. And this what contributes to the problems that I'm going to be talking about today. For example, the higher maternity rate in black women. There's also systemic biases. And systemic biases are those biases that arise not in the hospital, but behind the scenes, the less visible biases. I'm going to briefly introduce you to two genetic diseases, sickle cell disease and cystic fibrosis. And they do have very different symptoms, very different onsets. However, they both result in a relatively similar life expectancy, which gives them a good use of comparison. So sickle cell disease primarily affects people of African or Caribbean heritage, whereas cystic fibrosis primarily affects people of Caucasian heritage. And in the UK, there's around 17,000 people with cystic fibrosis, whereas that's with sickle cell disease, sorry, whereas there's just under 11,000 people with cystic fibrosis. Yet, for some reason, cystic fibrosis receives over 3 times the funding, treatment, and attention that sickle cell disease does. And this just goes to show that many diseases which affect ethnic minorities in certain countries often receive less attention, less funding, and that's not really fair, is it? The thing is, there have been measures to help um, bridge the gap between this. For example, last year, there was the opening of a sickle center specialist center in London. However, unfortunately, just only 6 months after its opening, with 42,000 petitions to keep the center open, it closed just a couple months ago. And this just goes to show that these biases in healthcare are not always happening in the hospital, but it's sometimes the diseases, the patients, the treatments that society deems more priority. And importantly, these biases are not separate. They very rarely happen one or the other. They reinforce each other. So, systemic bias often begins in research. Many medical studies primarily used white populations in history to conduct their research on diseases or treatments. And in doing so, we might not necessarily understand how certain diseases, certain treatments may appear on different ethnicities or more diverse backgrounds. And this is the data that we use to create our risk assessment tools, that the doctors use their guidelines every single day. So you can assume that, of course, there'd be maybe cases where there'd be less prevention or later prevention, which could actually affect patients' lives very dearly. A really good example of this is in South Asian communities. So, in South Asian communities, cardiovascular disease often develops at ages earlier than you'd expect, or without the typical warning signs, because of the way the research was carried out. And in doing so, oftentimes the first times a doctor is able to understand what is going on with the patient is where the patient comes in through an emergency department, perhaps a heart attack or a stroke. And if this had better preventative tools, we would have been able to diagnose these earlier and help treat and prevent this. So overall, this just goes to show that these biases, what starts off in research, have very adverse outcomes in a hospital setting, and they complement each other and affect each other very much. So, what is the solution to all of this? I've just been talking about what's going on, raising awareness, but if bias is learned, that means systems can be redesigned. And although it won't happen overnight, there are 3 steps that I think can be taken to help improve these biases. First of all, I think training to reduce subconscious biases in healthcare. So recently in school, I actually undertook a little program online called Hemisphere, where I learned about what these subconscious biases are in race and what they are. So if these were expanded to hospitals even more, making people aware of the biases that they may hold, and then training to help put them to the side, treat everyone as an individual, I think that would really help to improve this problem. Secondly, I think improving the risk assessment tools. Many of the risk assessment tools that doctors use on the daily are outdated. They were made from not diverse populations at all. So if we were to diversify them, do more research, carry out more research with different backgrounds, so everyone is able to be represented fairly, and in doing so, we'll understand how these different treatments may affect different patients and how conditions appear on different patients differently. And last but not least, I think increasing the diversity in management and leadership is really important too. For these decisions to happen, someone has to be able to make a change. And with more diversity in leadership and management, they'd be more likely to make that change happen. They'd want to make sure that their community is treated fairly and equally like everyone else. And also, when you see those people higher up in management as someone who may look like you, who's more diverse, that encourages you to carry out more research, look more into helping bridge this gap in healthcare. But to be honest, all I've been talking about today is what they can do. But I don't know how many people in the audience are looking into going into healthcare, but there might not be that many. So what can we personally do as a student body do? And as much as I have to say it, we might not be able to have a direct impact in healthcare, but just in general in the world, we should make sure that we be aware of our subconscious biases. Raising awareness is always the first step before we make a change. We should also make sure we treat everyone as an individual, not base past experiences on what we and how we act on different people of different backgrounds. Finally, we need to question stereotypes and assumptions. Stand up if you hear something that's not right, something that doesn't sit well with you. And in doing so, we can make the world a better place and bridge the gap in racism across the world.